I rarely see a bunch of surgeons sitting around trying to fix the inpatient throughput. Do you? You know, but a lot of ED docs have a lot of time invested, and because they're very frustrated, because if you've got, you know, your 4 beds, it's kind of, I remember one hospital I worked with, they said, you know, it's a real issue when we're taking care of an aneurysm in the hallway and the guy in our trauma room is eating lunch. You know, it's like when they're delivering flowers in the ED, you got a problem with length of stay. And, you know, on the inpatient side, so I've seen it all. I've seen it where, you know, patients are staying 2 and 3 days in the department. I haven't seen it a lot lately, but I'm sure, you know, you're all very frustrated. Once you're done with that patient, you want to turn it over, you want to get them out of your department and move them to the most appropriate place. My career history, I started consulting with Premier many years ago, in I think 91 to 96. Then I left for VHA, and then I came back to Premier. And the reason that I came back is because it's got huge databases of comparative data. And I knew that they would at least have the information that I could use to help you guys really solve the emergency department backup, because it gets to that point. Like I said earlier, if you can just get my admits out of the department, we can run our ED. And I think majority of you can do that. So in order to really understand it, I think it's very hard for you in your own organization to try and really assess that. I'm not pushing consulting, but if you can get somebody from the outside, it's hard to just do your ED, because you go to work every day thinking you're doing the best thing you can, the way you've learned how to do it. It often helps to have somebody from the outside come in and give you some heads up as to do the same thing. Well, when you're looking at the whole hospital, we're uncovering so many things that I think a lot of CEOs and COOs that are making these decisions are almost afraid of going there. Because, oh my goodness, if we start looking at the OR problem, we're going to have to deal with the surgeons. If we start looking at our capacity in critical care, oh my, you know, that may bring up staffing issues, all sorts of stuff. So when we get brought in, our approach is a combined approach. It's a combined approach looking at your clinical processes as well as your operational processes. You can see the same thing in the ED. There are things that are operational, you know, do you have the right staff on? And then there are things that are clinical. How many CBCs are we ordering? How many CAT scans are we doing? Utilization of resources, etc. So using these combined approach, you can see what we look at as far as operational systems to give you an idea. So you're looking at, you know, is our ED efficient? Do we have the capacity? Is it an ED problem? It may be an emergency department problem, but then again, it could be the attending availability, hospitalist availability to when you pick up that phone and say, I need to admit this patient, who's responding, when are they coming, you know, do you have people on call? We're starting to see a lot of the call issues. Are we paying for docs to be on call? And what's that availability, your backup for admitting the patients, your surgical scheduling? You've heard the Eugene Litvak studies, Boston University, where they looked at a lot of the processes of scheduling OR times and what day of the week. Ancillary scheduling and staffing. If your CAT scan's not available, if your MRI's not available, that's definitely going to affect your throughput. We saw issues, certainly, that they were doing, hospitals often do their outpatients first thing, right? You ever notice that? If you look at their schedules, if you look at your radiology schedules and their CT, they're often got their outpatients coming in early because they're NPO, and then we do our inpatients later in the day. Well, if you do your inpatient studies later in the day, they don't get the results till the next day, that's a bed that you could have had for your ED patients. Bed management, information systems, do you have tracking just like we have in the ED? Is there somebody looking at the whole hospital? I mean, I look at when we do these large hospital-wide, it's just a bigger ED. It really is. You've got a lot more people involved, but it's all about throughput and getting that patient to the right place at the right time, getting them out. So you need an information system to know where they are and where they are in their process. I actually even listen to nurses when they give report. at 7 a.m., they should be saying to the oncoming nurse, I'm talking inpatient now, this is day 2 of a 3-day length of stay. I rarely hear it because they're really clueless. So how much information do they know about the length of stay and how we need to move this patient through the system? Do you have housekeeping support, transport support? How many of your housekeepers go home at 3 in the afternoon? And when are your admissions, coming in, or your discharges don't even happen until after 1. So at 3 o'clock, we've got, 5 housekeepers going out and we have 1 left. So a parallel process then becomes a serial one. And then you get, lo and behold, you get the admission, you get orders, and now you call upstairs to critical care. Well, I see you have beds, if you even have access, because most of the time they don't want to let you see what kind of access of beds you have. But say you see, well, we have beds, but we had a call in, so you really don't have staff. Which is not okay. If you had, that makes me crazy when I think, but if you had patients in those beds, if you started the shift, what would you have done? You would have found staff. So if you have a call out, you need to have a backup plan. It's not okay for them to say no. On the clinical side, now you see the operational side of this, then there's the clinical side. The clinical side is the care management and the coordination. How are we coordinating processes? Are we coordinating home health services so that we can expedite this discharge on day 3 of this 3-day length of stay? Does anybody even know what it is? Resource utilization, accountability for services used, all those kind of, aligned incentives. If you've got your medical docs that are getting paid to come and see that patient every day that they're what's their incentive to discharge them? How many of you have the discharge if okay with? Have you heard about that? Discharge if okay with 6 or 7 different consultants. And you get that order at 3 o'clock in the afternoon, you're not going home that day. Even though the patient thinks they're going home, there's no way. Then it's all on that nurse on the floor. And by the way, is the nurse incentivized to discharge that patient? No. Why? Because they're going to, same as the ED, they're going to get another patient. So, it's really, you have to understand what are the incentives and how do we align them to make sure that, we've got, maybe we put a nurse who's a discharge nurse on the floor to make sure these patients, so they don't get affected by the next patient coming in. Physician order sets, so we know what the plan is, so you have protocols, so you know that on day 3, I told you about my husband's knee replacement, we knew which day those elastic stockings came off. I just, so he definitely, a lot of orthopedists, they have a plan. Medical docs are not the same. They don't have that same kind of on day 3, this is what we're going to do. Evidence-based outcomes, managing that with your order sets, proactive discharge planning. You should know these things. Even when they roll into the ED, there are things that we pick up on and learn about where that patient's coming from that we should start communicating about. This is, this patient, there's no way that they can go home. They're a high fall risk, etc. I would get social services in on this right away. So there should be, the good hospitals or the hospitals I've worked with that have really paid attention to this have put into place some cues that when they admit the patient, there would be a trigger that sends a signal to social services, case management that says, heads up, you need to start working on this discharge today, not when you get the discharge order. What's available in the community? Do you have CHF clinics? Do you have, the patients, we heard about the medical home. Well, boy, you can learn a lot about that, of what kind of resources are we sending these patients home to? Are they getting weighed? Or are they going to come right back into your hospital? I think we're going to see more of that because the hospitals aren't getting paid for readmission, so we're going to get more attention to that, what's available. So you saw my diagram. This is not the same one. This one really replicates from the time we get that disposition of admit. So you get the order that says admit this patient. So that's when the admission process starts. Well, we have the ED doc says, okay, so that's when your disposition says we're going to keep them. So we have the first one from the decision to admit to the time you get orders, right? And those processes that occur in there, the time that occurs in there affects Is your hospitalist available? Is your consultant physician responsive? Do we have pathways or order sets so that I know that all of our TIAs are going to the telemetry floor? So let's go ahead and start going, looking for the bed now. Is there a trust issue? And I have seen this. In one organization I worked with, when we interviewed the inpatient physicians, they said, well, it depends on which doc's working down there as to whether I'm willing to give them orders over the phone or whether I feel like I have to go down there and see them. So if you see that kind of behavior, you need to think about, do we, or, when we heard it the other day about PAs calling the attending to say, I have an admission here. Those attendings don't want to hear that. They want to talk to a doc, typically. From the time the order is written, or your orders that say admit to Dr. So-and-so on this kind of unit and this kind of diet orders, the whole orders, right? To the time a bed is assigned incorporates a whole nother set of issues. Now this could be a parallel process. A lot of the times the physician, the ED docs are the ones that say, get me a tele bed or get me a critical care bed. You got to make sure that that's a cohesive decision though, because if you're saying get me a med-surg bed and then the hospitalist shows up and then he writes on their telemetry, do you ever have those? And then you call report, they go up to the medical floor, and then the admitting nurses read it and say, ooh, this should have been tele. Well, that just doubles the time and starts it all over again. So it's understanding who's responsible for making that call of, where the patient's going. But once we have orders, then it incorporates all these other processes that need to be fixed. Who's responsible for bed control? Who's assigning the bed? Do we have housekeeping available to clean the beds? Are we using our telemetry beds too frequently? And you'll see some data that I'll have to show you where a hospital that they use telemetry way too much. Why? Why do you think that is? Did the patients really need their heart monitored? Why? The nursing staffing was better on telemetry. Everybody knows that, right? So that's why the docs want to put their patients on the tele unit. Well, when everybody wants to go to telemetry, then you're going to have backup in the ED because you don't have tele beds. You might have beds all over the hospital, but are you using those tele beds as you should be using them? Diagnostic testing and availability, we talked about that. Case management, physician rounding patterns, are they rounding late at night? Again, with the advent of hospitalists, we're seeing that 24 hours a day, hopefully, in the good, where I think the good hospitalist practices are 24 hours a day. They're not 9 to 5. They're not just docs that are taking unassigned call. That's not the hospitalist practice that we're really, encouraging. Discharge practices, housekeeping support. So if those, again, if you're measuring that time from the time you get the orders to the time a bed is assigned, then you need to, and that's a prolonged period of time, 2, 3, 4 hours, what's going on with these practices? This is not a physician issue. They've come around, they've done their orders, they've done what they need to do. Now we need to look at the hospital operations that support getting you a bed, making sure you have staffing. Now from the time the bed is assigned, so now, Jeanne, you got a bed, it's, we're going to 3A, 3506, to the time they get to a bed, then those issues, if you measure that time and it takes a long time for that, then you need to look at how are we calling report? Are they accepting report when I call the floor? Or are we getting this, they're busy, they're at lunch, we can't take report, all that. That's affecting your time from the bed's assigned to the time that they get out of the department. Shift change practices. I was with one hospital where they couldn't give report at any time they had shift changes. Well, there was probably 5 different times. So you couldn't call between an hour before, an hour after. So there's 5, 6, well, double that, 10 hours of the day that you couldn't call report. It was crazy. So what's the practice there? Who's transporting? If I've got a different group of people that are transporters and they're out having a cigarette, well, most hospitals are not smoking anymore, but or they're not to be found, they're in the cafeteria. How is transport affecting you? I like where my techs transport our patients. Once I get a bed, once I call report, I don't want to sit there and be at the bottom of the list 35, 40 minutes later when a transporter shows up. Are the nurses, the staffing on the floors appropriate in order to get the patient upstairs so they can, respond? Or is there a discharge unit? Some hospitals have experimented with a discharge unit. The majority of them fail. Anybody ever hear of the discharge unit? It's an idea where you move the patients down after, well, most of the time the patients don't want to go. They know about it. Oh, I don't want to go. The nurses don't want to leave them because remember, the nurses aren't incentivized to move them. And the docs don't really want that because when they go to the patient's floor, they're not there. So I have seen it where they've combined both an admission unit and a discharge unit, and that made a lot of sense because they were all there. And actually, in that unit, they were sending patients down who might need a last dose of antibiotic, and they would go down to the admit discharge unit and get their last dose while their bed was being cleaned upstairs. So, but that do you think that was the nurse on the floor's idea? Oh, let's move this patient so I can get a new one? No, it was somebody overseeing the whole big process. So having that kind of what they call a bed czar, somebody looking at and making sure and going up and saying, you got discharge orders, everything's done, all they need is a last dose of antibiotic, let's move them out. I got somebody else waiting for that bed. I'm going to show you a real hospital's data. This is a hospital, big, well-known hospital in Detroit. One of their smaller hospitals actually called us up and said, we've got major issues in their ER. The ER didn't really think it was because they had a huge ER. They had like 35 beds for about 30,000 visits. So they had plenty of beds. They had lots of staff. They had actually about a $3 million opportunity to reduce their staffing. They had that much staff in the ER because they just kept fixing the ER and fixing, more beds, more staff. But the patients were staying days. And the complaints were coming in from the inpatient hospital physicians that said, they'd say, by the time I see my patient, they're so upset because they've been in the ER for 2 days. So it was really complaints from the attending physicians that really drove this whole project. They were on diversion, and this shows the comparison here. 7.47% of the time that they were open, they were diverting ambulances. And the problem is they had about 4 hospitals in their general vicinity that they could have gone to. So they were losing admissions. So the hospital, because of their data, you can really calculate this out very easily by saying how many admits do you have a day? And for every hour you're on diversion, this hospital actually lost 1 admission for every 2 hours that the patient was on diversion. And it was $2.04 million in lost revenue. And that was real numbers because they were diverting. Yes, sir?
How do you get the loss? Is that
we got it based on the actual contribution margin of an admission.
And you had to know the number of arrivals by ambulance.
Right. And if you look at your ambulance and you know how many arrivals or how many admits you're getting per day and how many came by EMS, you can calculate that out. And so you can see the number of diversion hours up at the top. Certainly, they were on divert status for 324 hours, 4 times the national average. So it was clearly an issue. The CEO came out and said, I want the ED turnaround. They went to the ED folks and said, I want the ED turnaround time down to 2 hours for discharged patients, 3 hours for admissions. And they're sitting there going, it's not us. It's trying to get these patients out of the department. We actually quantified, and this was because the only way we could get this number was, the piece of paper in the supervisor's pocket. That's their information system. We took all the data from March and June and actually sat there and calculated how many hours patients were held in the ED and showed them. This was educational for them that in March of 2008 they provided care, 3,078 hours of care in the ED, approximately 157 days. And I did this to show them, help them see their staffing down there as well in an inappropriate bed. Meaning they shouldn't have been in the ED, they should have been somewhere else. And then we did that by every unit to see who else was competing for that same bed that we're trying to get at. OR was having a little bit of an issue, PACU. You know, if you look for other people that are experiencing the same problem, it's going to be probably the OR. This hospital didn't have a cath lab. Otherwise, I would go to the cath lab and say, how hard is it for you to get beds? Probably not. A lot of the times they pre-assign them well before, you know, those are definitely patients they don't want to hold on to. One of the other things we found in actually going out and flow charting the whole admission process at this hospital, and you can see it takes 15 steps just to admit a patient. And how many times are you doing that a year when you think of, you know, your admission percentages and the amount of time? And what we found, interestingly enough, and I don't know if you all have done this, but they actually didn't get admitted, I can't see it, until the very end, where the registration person was then admitting them. So when we looked at all their length of stay data, it was really bogus because they weren't even capturing all the days that they stayed in the ED. You know, I mean, I wonder if you all know that. Some people call them ghost beds. They make sure that you have a ghost bed so you can, even if you're holding them in the ED, the hospital at least gets them admitted. There's a lot of patients that we looked at in this study that never got admitted because they were admitted from the ED, never got out of the ED, and were discharged from the ED a day and a half later. That hospital couldn't get the admission. They could all they could charge for was the admission, the ED visit. So make sure that you're, you know, as soon as the doc decides that the patient needs to be admitted, go ahead and get registration to admit the patient. So cumbersome process. Again, more data on, you know, just, you know where I'm coming from. I do this for EDs all the time, so when I go in and do a whole hospital, I'm going to look at the same kind of data. Is there a day of the week variation? This was, the question that we asked was, where do our admissions originate? And is there a pattern of admissions by day of week? So you can tell the big blue, that was ED. The dark blue was OR, where the admits are coming from. The black was critical care. So the patients actually went right to the critical care area. But you can tell on Monday, which is our big surgical day, we're going to have a lot of problems. We've got more people competing for that bed. It's kind of like, you know, when you say of all patients admitted, 85% come from the ED. Hey, then I've got fewer people that I'm competing with. If I'm admitting, if the ED only is responsible for admitting maybe 45% of the whole hospital admissions, then you've got a lot more others that you're competing with for that same bed. Okay, so understand where that is and who's going for those admits and what day of the week is going to be a difficult day. This may be an opportunity to smooth that schedule out for the OR. What time of day do they come in? Right here, you can see it would have gone off the graph was the 7 a.m. surgical time. And what we learned from this was a lot of times they were already assigning the surgical beds before the day of admission. So we were holding patients in the ED even though there were beds throughout the hospital. They were just being held for surgeries the next day. How many of you are doing that? Not, you know, but there's hours of time that those beds are sitting there empty. And, you know, so you really have to, the hospital that I was a house supervisor, patient placement coordinator for 2 years, and we never had an empty bed. I was a bed czar. When they came up with the idea of being a bed ahead, I was like, well, that's no new concept. If I wasn't a ICU bed ahead, a tele bed ahead, and a med surg bed ahead, I wasn't doing my job. So it's understanding where those beds are and filling them when the bed when the admission comes in, and otherwise you're going to be behind all the time. Okay, let's see. By the receiving unit, where were they coming from? And whoops, we did another one of how many hours during the months of March and June, how long did patients wait for an assignment by the requesting unit. On average, the ED down here was 23 hours it took on average to assign a bed. So you can imagine, you know, how much time it was taken during this period of time. Again, this was the capacity and census by unit. So what this showed, the red line was their total rooms available. And look at that, you know, yet they had beds all over the hospital. They just were not either staffed beds or they're the wrong unit. They had one unit that actually only had about, I think it was 12 beds. They were dedicating it to orthopedics, and the average daily census was 2. And yet the ED was backed up for days. So understand what's going on. You know, it's not that there's not beds. There may very well be beds. So we started to look at, it's not showing on the other side. Can you see it in your, it's kind of critical to see that the right side of this slide. What we looked at is for the high volume diagnoses, where are these patients going? So for instance, heart failure. And this comes from one of the Premier databases, Clinical Advisor, which gets thousands and thousands of patient UB92 data for about 600 hospitals or so. So we're able to compare your process with others. So here, what it's showing us here is the hospital that we were studying, 90% of the time, or 90% of their length of stay was spent in a telemetry bed compared to 31% the rest of the country, or the top decile performers. And we call those top decile the HQID those hospitals that are getting great outcomes. So clearly this was educational to the attending physicians about where patients go. And not every heart failure patient needed a tele bed. We did the same thing with pneumonia, and you can see your graphs in your handouts that show the distribution. So this was, we looked at length of stay. It was not a length of stay issue. It was what beds were being utilized. We found, and I don't have the slide on it, but we actually found that endarterectomies, post-op endarterectomies were going to critical care. 100% of them. Not the high acuity ones, all of them. Well, we looked at the rest of the country, and nobody post-endarterectomy was using critical care beds. Well, if you use that critical care bed for your post-endarterectomy, when your highly acute patient comes in the ED and needs, the AMI comes in and needs that bed, it's not going to be there. So understand, it's a utilization issue of what's being utilized. We looked at surgeries. Are they being, where are they going by day of week? How many surgeries are we doing? Was there an opportunity to maybe go to the orthopedist and say, would you be interested in moving your surgical day to maybe Wednesdays so we don't have the backup? And that's, if you want to learn about surgical scheduling and smoothing, look up Eugene Litvak. He works a lot with the IHI. And the problem is, I think most of the work that he's done it in academic medical centers where you can get the surgeons to change. In your community hospitals, it's really more difficult. I'll go through these slides very quickly because it really just shows that we learned that it wasn't a length of stay issue. A lot of times we think, oh, well, the length of stay must be too long. It wasn't. It was about when they do stay, they're using the beds inappropriately. We're able to look at by service line or business line, by DRG, the volume of patients coming in with that certain DRG. There's some areas, let's see, renal failure, they're at 5.7. The expected length of stay was 6.2, but the better practice was 4.6 days. So you get to understand, do we have a length of stay issue? Is this a case management problem? Or again, is it how we're using the beds that we're using? This was by payer mix, our Medicare patients staying too long, et cetera. Physician specialty. Admission source, where are they coming from? We heard some of the mortality and morbidity about patients who come from the ED are sicker or stay in the ED. So our length of stay from patients coming from the ED, but remember, then we learned that they weren't even being admitted until they already spent 24 hours in the ED. So some of this had to be taken with a grain of salt. And again, impact on ED admissions on overall length of stay. So this is I'm just kind of giving you a taste of the kind of data that you have to get into to understand the whole hospital issue. And you can't just focus on one thing saying, oh, it must be length of stay. It may not be. It may be how you're using, are the nurses staffed, et cetera. This is the example of the capacity on the inpatient side, just like we do in the ED. Do we have enough beds? And you can see I think One North was their telemetry unit, so they were at 90% capacity. But that 2 North was only at 20% capacity. So when we showed administrators this and said, we've got a distribution problem. You have, a full staff or full complement of nurses on 2 North taking care of only, on average daily census, I think it was 2.5 patients. We need to distribute your patients differently so that we can make sure that they get to the floor. And this was a graph of the housekeeping availability and the discharge time. And you can see this is the times that discharges occurred. So they discharged from the information system, time of the bed request, and the time of bed assigned. So you can see that there was definitely a lag, but this doesn't happen, 1 o'clock was 2 o'clock was your peak times. So, and we looked at the first 5 months of 2008, only 9% of patients were discharged by 11 o'clock. So how many of you have got all these kind of processes where we have a discharge time? Does it work? Exactly. It doesn't work. I think that if you start doing this and giving feedback to attendings and say, you're only discharging your patients by 11 o'clock 20% of the time, they'll discharge them the next day so their numbers will be okay, So it doesn't work all the time. It's good to understand what time so that we make sure that we've got housekeeping available when your discharges occur. So we'll go over just some best practices or solutions. Again, I know it's hard for you to go back. Yes?
What's the top quartile for discharge by 11 a.m. in hospital service? Is that available?
Yeah, I don't know if that data is available. I'm sure it is by each individual hospital, but I'm not sure I have a comparative benchmark on that. And it's going to vary based on the way your hospital operates, whether you have diagnostic services available earlier in the day. I think a lot of hospitals are striving for 90% of discharges to occur before 11 o'clock because they believe that will make them more efficient and allow the beds to be opened. They then can staff better, et cetera. But if you don't have, if you've got a physician group that that doesn't round until 5 or 6 o'clock in the evening, I've seen discharges happening at 6, 7, 8, 10 o'clock at night, or that's when we learn the beds are empty, which is a whole nother issue, right? That they don't take the patient out of the, I've been interviewed nurses, it's really embarrassing for them, well, not the nurse, but for the hospital when I had one of the ED nurses that said, yeah, I had my aunt was in for a cholecystectomy and she had complications, and when we came in 2 days later, we tried to admit her and we couldn't admit her because they never discharged her. And the ER nurses know that that's going on, and they're like, that's why we can't get beds upstairs. So it happens all the time, and we've seen, we put things in place where the inpatient nurse managers are more accountable to make sure that those secretaries take those patients out of the system. You cannot go down to that secretary and say, just don't discharge Mr. Jones yet, even though he's been long gone. So we need to have a very practical, good turnaround time as far as awareness of when beds are available. Exactly, and that's one of the solutions. Let me kind of go through some of the solutions, but ensure nursing staffing is adequate and ensure a backup plan. I'm not talking about ED, I'm talking about the inpatient. When I was the house supervisor, we were also responsible for staffing, and we had a contingency plan. If we had empty beds, okay, somebody could go home on call, but be ready to come back, because we got admits down in the ED. We never closed beds. It's kind of like I say, the hospital administrators say you can't go on diversion. We don't want, the ER can no longer go on divert. Anybody hear that? But it's okay for critical care too. When they say we don't have enough nurses tonight, so you're going to have to hold that patient. They've just diverted. It's not okay. Ensure adequate access to outpatient scheduling exists. We found this happening when they had broken outpatient scheduling. Let's say you're in for your knee replacement on the left, and they couldn't get MRI access for weeks or months, they'd say, oh, well, let's go ahead and get that study done. Or while you're here, let's do your colonoscopy, right? Adds to your length of stay, and it does not, and the hospital doesn't get paid for it. Smooth your surgical scheduling practices, at least understand how they affect your hospital throughput, and are there certain days that you know it's going to be a terrible day because of the way the surgical scheduling is done. Private rooms, I know Florida is big on, you go down the Florida highways and there's huge billboards that say, you know, our hospital now has private rooms. They're building a lot, just as many as are being built for seismic changes in California. Florida's going for the individual beds. It's a whole lot easier to run a hospital where you have private beds as opposed to semi-privates. But then I love it when you go back and they say, well, no, we don't have, all we have is male beds and you have a female. We have 3 male beds, and by the way, we could have put one of those males together, but we don't really want to because that would require more admission and more work. So understand those kind of behaviors. Centralized scheduling of inpatients and outpatients, so everybody understands coordination of care is critical as far as throughput goes. Implement a one-call admission access for physicians. You know, we did this in Florida where the docs, at least when they want to get their patients admitted, all they have to do is call one place rather than multiple places. Otherwise, they're going to say, just send them through the ED. Automate the bed tracking process. You can see, I think this is probably teletracking being used. So again, they see the big picture of what's going on. Ensure transparency of the bed management system. I was just at a hospital in San Jose, and I loved it because the ED secretary sat there in front of the ED tracking system, and then she said, and here's my hospital tracking system as well. Wow. You know, a lot of places won't even give the ED access. We don't want them to know. You know, it's not okay. You have to have transparency. Consider a case manager for the bed czar. Here a lot of times we have nursing responsible for bed management. Well, they're also responsible for their nursing budgets and things like that. So you've got, you know, Lucy running the candy machine. And when they want to say stop, they say stop. So, but case management is accountable for length of stay, but they have no authority over it. So probably the better practice organizations I've seen have case management over hospital throughput. Assign only ready beds. How many of you get, okay, you're going to go to 305, but it's not ready, right? Don't give me a not ready bed, because now you've just put it on me to decide whether it's ready. So then what happens? You call upstairs, is the bed ready yet? No. Is the bed ready yet? And then they're like, the ER's calling up here. Don't even assign it until it's ready, okay? And then that puts all the accountability on the admitting department for what they're responsible for doing to begin with. They expect nursing staff to call for the patient report. This was a process my hospital did. Again, it's one of those things good I went back to work and saw what reality was. It worked for a while. So the inpatient nurse was responsible for calling the ED and saying, okay, I want to take a report. Makes a lot of sense to me. If you've been a med-surg nurse, you know, you've got 7 patients, you've got somebody who's 400 pounds on a commode at the side of the bed, and they're saying the ER's calling. You know, if you empower me to say, call the ED, then I can wrap up what I'm doing, get my pencil and paper, go down and sit down and focus and take report and call you. It's easier to find the ED nurse sometimes than it is to find the inpatient nurse. Enforce your admission, transfer, and discharge criteria. Predetermine the transfer potential of ICU and PCU patients. I saw this being done at Anne Arundel Hospital in Anne Arundel, Maryland, I believe. Yeah. Anyways, what they were doing was they would, on the floor, on the critical care, decide, the doc every day would say, yes, they can move, no, they can't move, or call me and we'll discuss it. And that way you had a plan. So they knew if they got an ED admit, then oh yeah, this one was a level 3. If we needed the bed, we can move them. Let's go ahead and facilitate it. So you didn't have to then start finding, and then what it is, because I've been on those phone calls, well, let's see, which doc should we call? Who's going to be willing to move their patient? This way it was done every day when they made rounds. align management incentives with financial systems. This, anybody paying the nurses downstairs for taking care of admitted patients? Definitely seen that. What's the incentive for the inpatient nurses to accept another patient? And not if they've already cut their staffing back. I've seen it, I don't know how many times, 100 times, where you go in and you look at your nurse staffing on the inpatient, they're all meeting their budget. They're at 100%, they're perfect. Well, that's because their budget was based on last year's volume, and that the year before that, and the year before that. And we never compensated for those patients who had waited in the ED for days. You know, that would have been volume if they had come up to the floor. So Miami Valley in Toledo, Ohio, what they were doing was actually transferring the hours. So if the patient was held in the ED, for those hours that you provided nursing care, you charged the inpatient unit to which they went to. So now all of a sudden it was an incentive on the inpatient manager's part to get that patient upstairs, because otherwise you would be hitting them with a big bill for the nursing care you delivered. Automate physician access, CPOE, so if they're in their office and you call them, they can jump right online and see the lab results. An express admit unit, anybody have an express admit unit? Basically, it's just getting those patients bypassing the ED. We have one, we call it the extended care unit. It's 10 beds, sometimes it's open. I think now in the winter months they staff it. When they first opened it, we just didn't have enough patients to justify the staffing, so they started finding patients from all over the hospital that would be appropriate for that unit. And the patients will go there. So now, I just saw an email the other day that said, you know, if you have a patient and they have orders, move them. And that really came out from the ED physicians, because they want those admitted patients out of their beds so they can see ED patients. 7-day-a-week access to ancillary testing. You know, if you've got a 5-day hospital, you're going to have hospital throughput issues. Unit-based case managers, a physician advisor. So the physician advisor can go out there and say, you know, this is not okay to the rest of the docs. You need somebody who's not there on the job retired. I know a lot of chief medical officers that are like, okay, I'm ready to just take it easy now that I'm in administration. They need to be out there, and they're really key to that whole hospital throughput. There was one hospital in, I think it was Brooklyn Hospital Center in New York City, or, you know, one of Brooklyn, obviously, where I loved it because the ED, the director, the ED medical director, was also responsible for, I think, residency services or whatever, but he could go up to the critical care and triage and say, nope, this one can go out, nope, this one can stay, because he had patients sicker. He said, I got sicker people down in the ER than are up here. And I thought, wow, what, you know, I mean, I've never seen it done that way, just the right circumstances, but it made sense.
So here's another thing that you might not have thought about. Do you know if your ICU is a closed ICU or not? In other words, can any doctor admit to the ICU, or do you have critical care doctors manning the ICU? If you have critical care doctors manning, this is advantageous to you for a number of reasons. In particular, they're better at moving patients out of the ICU and having shorter lengths of stay, which opens up those beds for you when you have critical patients downstairs. They're also showing that when you have critical care trained docs running an ICU, survival rates are better, adherence to sepsis protocols are better. I mean, I would suggest you the quality of care is better. But many hospitals, you have, you know, physicians who've been doing ICU care and allowed to admit to the ICU for their entire careers. They're not giving that up quite willingly to the intensivists, but you might be a champion for your critical care guys because it would help you. And it's probably something you never think of, well, how will that affect me?
Right.
In fact, there's a lot of increasing data that when it's a closed ICU, it's better for the ER.
Yeah. Anybody have an EICU services? You know what EICU is? Electronic ICU. It's like a telemetry for Holmes Regional down in Florida. Implemented it while I was there. And what they had 3 hospitals, and they basically had a command center where one of the intensivists would sit there and be able to access patient information from 3 different ICU critical care areas at any time. And so I was going, oh great, we can get them to facilitate throughput too. And they said, we'd really like this program to be accepted by the medical staff first, Jeanne, before we push that. But it's a perfect place for them to say, you know, they don't meet criteria anymore, they need to move because we got people in the ER waiting to come in. So, yes, I'm sorry.
Whose responsibility for those patients? Is it the ER docs or is it the inpatient?
The express admit unit, as soon as we get admitting orders, it's the attending physician. It's not the ED doc. Now, our extended care area, the ED docs can use it. If they've got somebody they're hydrating or somebody abdominal pain that they want to observe or keep an eye on for a few hours longer, they can use it and they're responsible for the patient. But if they're actually admitted to the hospital, it is the hospitalist or whoever's attending that they call. Is that a question? A stretch. Okay. And provide physicians severity-adjusted data. We have, again, this comes from our clinical advisor database. This was for one DRG, and you can see the comparison between cost per case and average length of stay. We call it the doc in the box. There are certain docs that were considered the better performers. Now, that's where I want my chief medical officer to go and have a discussion with Dr. G and Dr. B.E. because they're costing the hospital a lot more. And they can't say, oh, well, my patients are sicker because we've already severity adjusted the data. So it's given the physicians feedback just the way you guys are expected to get feedback in the ED. Implement evidence-based guidelines, again, so everybody predicts and knows what the process is. It's standardizing a plan. It's not cookbook. It's really everybody knows what the plan is and we can coordinate it better. There might be variances, that's okay, but everybody at least knows. This is the one that I talked about, have the nursing. This is I loved it. The group in Florida, one of the nurses came to a meeting and said, you know, I was thinking about it. Rather than letting the patient call their family to come pick them up, maybe we should. I was like, oh my gosh, what a great idea. You know, and my mother-in-law, bless her heart, when she was alive, she had her hip fracture, and I remember her calling me, and I was at home working, and it was about 9 o'clock. I said, well, Grandma, you're going to get admitted, getting discharged today? And she said, oh yeah, but you're working, honey, don't worry about it. You don't have to come get me till 5. I mean, she's been having her meals delivered. She likes her back rubs. She liked that inpatient care. They're not in a hurry to go home. But if the nurse had called me the night before or that morning and said, what time are you coming to pick your mother up? What time do you want me there? And I'll be there. So it's a completely different message about setting discharges.
Have you heard of a discharge ban? Have you heard about this idea? And actually, I'm pretty sure Mr. Yardley came up with this. As I told you, we are great at problem solving and finding. So he can't get his patients upstairs, and one reason is with very many the middle-aged people like me, we're working. So when it's time for Grandma to come home, who's going to go fetch the old girl and get her out of the hospital? And so that was the problem. They realized that just sheer transportation issues were keeping people in the hospital for one more day. And so the hospital said, let's just try this. Let's have our own van and drop these little people off right at the door. There's an ER doc thought about that. They're saying it's brilliant. How much would it cost for the hospital to have a van and a driver? Not very much. And they were able to open up beds much quicker, which then was advantageous for ER. So you will find, and especially if you are ER leaders, your hospital, your organization will turn to you because you have a reputation for being an innovator, a problem solver, and you can turn some of those capabilities to the inpatient side, and it will help your department too. Yeah. I just think that's incredibly clever. I love the idea of this little van dropping all these folks off, willing or not to go home.
Until you drop them still in their hospital gown on the street corner.
Yeah. That's in Los Angeles, but we won't go there. No, I did work with Riddle Hospital outside of Philadelphia. They actually had issues with getting EMS available, ambulances to come and get their discharged patients every day. Again, they were competing. And they finally said, let's just go ahead and schedule them. So every day at 1 o'clock, there was an ambulance there to pick up, and they rarely had a day where they didn't have somebody that needed it, but it's the same concept or similar. Holding unit managers accountable for appropriate notification of discharges. You know, I've seen it where, just in a hospital down in Phoenix, where the admitting office actually got 2 faxes. They got the discharge from the information system, and then they got another thing from the hospital housekeeping staff. So that it was almost a backup system to know when that bed was empty. Reorganize bed control and case management. I talked about that a little bit already. Develop a consistent process to communicate patient discharge to bed control. Whether that, another place I was just at in Florida, they had the guy's name, I forget what it was like George. And I said, well, what does George do? Well, actually, George stood at the front of the hospital, and as patients were leaving, he watched for their discharge bands, and if they had a hospital band, he went and cut it off, and then he called bed control and said, Mr. Jones has now left. Why? Because they couldn't trust, I don't know whether it's they couldn't trust nursing, or nursing has too many other things to do, and I know what that's like. If I had to go, you know, and call somebody and say, my bed's empty now, I've got other things and other priorities to get to. So think of other ways to do it. I know one hospital, Hoag in California, they wanted to put, you know, kind of like one of those tags that they put on when you leave the store that would burst in ink, and just to communicate, or some kind of thing when they went through a metal detector, it was like, okay, it's a discharge. So because they had such issues with getting that communication going. And hospital-wide high census alert system. Anybody have that? Kind of like we could code gray, high census. Let people know we're high. You know, I was in another organization where when the physicians signed on or logged onto the computer system, it would pop up and say, we are either in red, yellow, or green status. Please, you know, if we're in red, please discharge your patients or transfer as you can. So letting everybody know that, and so there's practices and processes that change when you're in high census. Multidisciplinary rounding, we're seeing a lot of that. Yes, sir. Yes. That's what happened. What the comment is that it becomes, people get alarmed out, or, you know, whatever they call, they just don't even, because my point is, why aren't we doing these things every day? You know, in some places it's like the managers, when the high census alert is called, they get paged to go to their units and facilitate discharges. And I've seen them in meetings get the page over their pager and then just go back to doing what they're doing because they just get insensitive. I agree with you, that can happen. Multidisciplinary rounding. Seen this very effective where you've got a team, case management, social work, the physician, might be physical therapy. Let's move these patients and get them discharged. Boxed lunch, this was another thing that I learned from Florida, was let's go ahead and plan. So it's a script. When the patient gets admitted, you tell the family, on your 5th day of your 5-day length of stay, we're going to plan to send you home with a boxed lunch. And that way, and it will be ready at 10 o'clock when you're coming to pick your mom up. That way you don't have this worry about, hey, I'm going home to a house that hasn't had milk in the refrigerator for a week. I have no food there. I need to be ready. So we're going to send you home with a boxed lunch. That was very effective in one of the hospitals. Plus it developed a script for the nurses to participate in. Pre-scheduled ambulance availability, we talked about that. Hospital-based transport service, we talked about that. Consider a free home health visit. Again, if you're uncomfortable about sending that patient home and what kind of situation you're going to find when you get there, go ahead, and some hospitals will allow one free home health visit, so you're more comfortable about that. Partner with payers to offer community-based case management. A lot of that is coming about, with patients with CHF, et cetera. Multidisciplinary steering committee, this is not something the ED should take on. You might be a part of that team, but this is something that's so much bigger than the ED that you really need a multidisciplinary group putting it together. Utilize operational and clinical data, just the same way that we drive performance in the ED, needs to be hospital-wide. Educate everybody on what their role is. There was a hospital, it's southern Chicago, and it was one of the Saints, so it's Catholic healthcare system there. But they did a whole process called MP3, move the patient in 30 minutes. No matter where they were, they had to move that patient in 30 minutes. And so the whole executive team got into this, and they actually came out and you know, when they kicked off the project, they gave out cookies that looked like MP3 players. And then they had a whole budget to pay for MP3 players to give to anybody they may find doing something good that would affect their throughput. So if they saw a transporter respond to transporting a patient rapidly, they'd say, here's your MP3. You know, so it was like these little rewards that incentivized staff to think about it. What's in it for me? Well, if I get there and I, discharge that patient, or the housekeepers, if I turn that room around fast, I might get an MP3 player. It was just kind of, I don't know how long it lasted, but they got huge results because they were invested. This is not a project. This is not just a little project. This is hospital-wide operations, and you see how much it affects. So it has to be, educate everybody, reward everybody, provide monthly report cards, and just improve. Okay, other solutions, express admit, clinical decision unit. There's, if you're 100,000 visits, you're an 800-bed hospital, you can probably have one of each. If you're much smaller, you probably don't need either. If you're on the average, you might use one, but call it both, but understand what are those issues that drive, whether we're a clinical decision unit is usually responsible by, for the ED docs take care of the patients. If it's an express admit, it's usually the attending that takes care of them. Hall beds on inpatient units, we've heard the Vicello, stories about that. Most nurse executives go, not gonna happen here. I don't know that I'd wanna stay in a hall bed either, but it's a better solution than some ERs. Housekeeping and transport services dedicated to case management, so that they know, or to bed management, so they know where to deploy their resources. Bed management assigns the bed, okay? So independent of nurse staffing. So it doesn't matter if you don't have nurse staffing, that's not my problem. You need to find it. If you've got beds, that's the department where you're going, their responsibility. A no refusal policy, meaning you can't say no. I mean, the hospital I work in now, you cannot say no. It's not an option. All the inpatient managers have to have a backup system. If they have beds, those beds are open. Let's see. Fax report, bedside report. I'm still a good old talk to the person on the phone. It takes me more time to fill out a fax report and fax it and then call upstairs, did you get the fax? Than just calling up and they answer it. And where I work, I hate to say it, I don't hate to say it, but I'd say 95% of the time I get the nurse who I'm calling report to. So that's the fix that you have to make it a priority in your organization. If that's what you exist, is to admit patients, so. Well, yeah, and they've done studies where all they had to do was go on the nursing unit and outline where that bed was going to go in the hall, and they never had to put a patient in it. Because it was a threat to the inpatient nurses to say, let's get this patient discharged. We don't want to have to put that patient in a hall bed. So lots of options, lots of solutions. I wish you all well. But again, it's a hard presentation to ED folks because you're not going to be the ones that should be responsible for fixing it. You're affected by it. So, Sherry?